Here's what we're going to be talking about tonight in a nutshell. I'm going to give you an introduction to adverse childhood experiences, otherwise known as ACEs. Raise your hand if you've already heard of ACEs. Yay, I'm so impressed by that. Okay, great. And then we're going to just do a brief overview of trauma and stress. That will give you a really good fundamental understanding as we launch into resilience. We're going to look at Ginsberg's model of resilience and other factors that promote resilience in children. Then it says we have an official break. And then we're going to start filling our toolbox. So I'm going to try to get through the heavier content-related information up front and give you a really good background so you have good foundation. Then we're going to spend the second 2/3 of our time together tonight really talking about resilience interventions. And I think about those as protective factors that will help promote strength in your family. All of us can benefit from it, and when I start to talk about the interventions, I'll talk about how and why I'm using the ones that I'm using for promoting resilience in families. And then finally, we're going to talk about self-care for all of you. I know some of you are going, what? But we're actually going to talk about that and encourage. So why are we doing this? First of all, it's important to understand what adverse childhood experiences are before we launch into talking about ways that we create protective mechanisms for children. At the Children's Health Alliance, which is where I've done and built this curriculum work, we decided to do this in a 3-part phase. And so you're going to see actually tonight all 3 phases. The first thing we decided to do is we wanted to educate all pediatricians in the Portland metropolitan area and some pediatricians in Salem about what ACEs are. Because Robert Bloch, who was the former president of the American Academy of Pediatrics, pointed out that ACEs are our #1 health problem facing children and adults today. And the more people that know and understand what adverse childhood experiences are, the better we can then promote resilience and discuss mitigating the effects of things like adverse childhood experiences. So the first thing we did is we just wanted people to understand what ACEs are. So let's talk about that first. If you haven't had a chance yet to look at Nadine Burke-Harris's TED Talk on ACEs, I encourage you all to do that. Just go to TED Talk and search Nadine Burke-Harris. It's got millions and millions of views. It's a wonderful, about 14-minute segment on what ACEs are. In a nutshell, though, ACEs are adverse childhood experiences. The initial ACE study was done in 1998. It was a collaborative study between the CDC, the Center for Disease Control, and Kaiser Permanente. Over 17,000 patients took this study. Something to note is that it was a retrospective study, right? So what that means is adults took the ACEs study, the questionnaire, and you'll see what the ACEs are in just a moment, and they were reflecting on things they had experienced in their childhood, and then reporting health factors and health effects that they currently had. So they were looking retrospectively on things that they had experienced, and here they are. There were 10 ACE themes that were pointed out. You can see 3 in the abuse category, 3 in the neglect category, and 3 in household dysfunctions. For those of you that, you should all have the slides in your packets there, but it's physical, emotional, and sexual abuse, physical and emotional neglect, mental illness, that's of your parent actually, an incarcerated relative, witnessing domestic violence, substance abuse, or experiencing your parents' divorce. Those were the 10 ACEs that Felitti focused on when he did the ACEs study in 1998. And what the people did is they reflected on that and said, yes, I experienced 1 or more of these ACEs. And then they also talked about health outcomes that they have currently, whether that be diabetes or other chronic medical conditions. And we'll get to that in just a moment. So ACEs are common, it turns out. 67% of people have at least 1 ACE, right? If you have a divorced parent, you've got an ACE. If you had a mom with depression, you've got an ACE. If you experienced physical or emotional abuse, there's an ACE. So 67% of people, so 7 out of 10 people that you interact with on a given day have experienced at least 1 adverse childhood experience. More interesting is that as ACE score increases, we'll see more long-term health effects. In fact, 12% of people have 4 or more ACEs. So that means 10 out of every 100 people, a little bit more than 10 out of every 100 people, have at least 4 or more ACEs. I know you're all now going back and you're counting your ACEs right now. Here's the news. There's a strong correlation between childhood trauma and adverse health. In fact, the higher your ACE score, the higher risk of disease in 7 of the leading causes of death in the United States. And so you can see here that the numbers go up and increase for negative health outcomes the higher your ACE score becomes. I'm specifically going to talk tonight about ACE effects in children because that's often what's most interesting for parents. But what we find is that the health outcome and behaviors in children are significantly impacted. Developmental delays, growth delays, asthma, pneumonia, viral infections, learning disabilities, obesity, headaches, hyperthyroidism, pubertal changes. All of these things are associated at higher rates, and they correlate with a higher ACE score. So lower ACE, lower long-term health effect, higher ACE, higher long-term health effect. Here's some other interesting ones related to specifically children. With an ACE score of 3 or more, a child is nearly 4 times more likely to have developmental delays. And with 4 or more, a child is 32 times more likely to have behavioral problems in school. Young children with 4 or more ACEs are twice as likely to have BMIs that are associated with childhood obesity, and children exposed to intimate partner violence are 80% more likely to be obese by age 5. So obviously education becomes really important when we're talking about long-term health effects with children. Another significant statistic is related to maternal trauma. Mother's trauma, both recent and past, increase the risk of the following with their children: child neglect, the involvement of Child Protective Services, CPS or DHS, and the use of physical punishment. So obviously when mom has experienced trauma in her own life, her ability to parent in a healthy fashion becomes significantly affected as well. ACEs, as I pointed out, are the single most unaddressed public health problem facing our nation today. So at the Children's Health Alliance, they took a really strong initiative to educate pediatricians about ACEs so that they would understand that having an intervention regarding adverse childhood experience would be significant to potentially mitigate the long-term health effects that were present. I'm really excited. I get to talk and train pediatricians, and CHA has trained 125 pediatricians throughout the Portland metropolitan area. But I really get excited talking to parents. I got to actually practice a lot of the curriculum development with the pediatricians, and the pediatricians who are part of the Children's Health Alliance have all been trained in the resilience interventions that you're going to learn later. But it's not very often that I get to practice on doctors and then they practice on you. It's usually vice versa, right? Doctors practice on you and then you learn something from it. But I actually got to practice on them first and develop the resilience interventions that worked for them in their practices. And so through Children's Health Alliance, the first step was educating people about ACEs and about what adverse childhood experiences are. The second part was learning what is trauma and what is stress and how does it affect our bodies. What are traumatic experiences? Traumatic experiences are events that threaten one's safety, physical and or emotional health. They can be both physical trauma or emotional trauma. What is traumatic stress? Traumatic stress occurs when a person's unable to absorb the process and grow through a traumatic experience, and the fear persists. It's an emotional reaction to trauma. How does traumatic stress occur? When adversity happens, some people are able to bounce back. We call that resilience. But it's been reported that 20 to 30% of parents and 15 to 25% of children have traumatic stress that every day impedes their daily function, impacts their compliance with their medical treatment, and impedes their own recovery. However, not all traumatic experiences like ACEs result in traumatic stress. So for instance, you can experience an acute trauma, right? Here are some examples. 9/11, the Boston Marathon, school shootings, You can be in a car accident. They don't have to be as huge and significant as some of those things. It could be being in a car accident, being bullied in one incident at school. We're really optimistic about that. About 80% of people will recover and can benefit from therapy, short-term therapy, and bounce back from that. The type of trauma that we're talking about that occurs with adverse childhood experiences is chronic, repetitive trauma that happens to a person over time. So examples are physical and emotional or sexual abuse by a family member that starts occurring and continues to occur over time. The issue's not necessarily the incident, but rather the betrayal of trust from a primary attachment figure. So complex trauma is obviously much more difficult to recover from than acute trauma. And I'm not minimizing acute trauma in any way. If you've experienced an acute trauma, it's very difficult. But complex trauma often requires more intense therapy over time and is more difficult to recover from and takes time. This is a really interesting visual image for you. You can see here that this is a child's brain who's been affected by trauma. On our left-hand side is a healthy brain. This is a PET scan. And for those of you that aren't familiar with a PET scan image, this is as if we sliced the brain this way and looked down at it. And so this is from a top view of a brain. Up in the front where it's nice and red is your frontal lobe. It's right here in the front of your brain. And then you see the two circles that are well lit up in the temporal lobes on either side of your brain. But it's a cross section and we're looking down into the brain. On the right-hand side, you can see a child that was raised in a Romanian orphanage. The two spots that are circled again are the temporal lobes, and you can see that activity in the PET scan is almost non-existent. Your temporal lobe is responsible for emotion regulation and arousal. Those are really important things when we're talking about how we would cope with a traumatic or stressful experience. But when you haven't had someone there to scaffold those experiences, to explain them to you, to talk about stress or trauma that you've been through, or you're neglected in very significant ways, physically, emotionally, you're not getting the feedback in your brain and the little circuitry that it requires to make those really important connections for those parts of the brain to develop. But I also want you to notice there's not as much activity in the frontal lobe either, right? The part on the left-hand side that's nice and red and lit up isn't as much so on the right-hand side. Your frontal lobe part of your brain is your executive function. Impulse control, attention, organization, sustained attention, memory. A lot of those things are happening in our frontal lobe. So when we see a child that's, you saw a couple slides back, having a lot of behavioral problems, the first thing I hear about in my office is, boy, this kid must have ADHD. I always want to rule out anxiety, depression, trauma, because I want to make sure that these other parts of the brain weren't affected by something much more significant. Okay, so what's the next step? First, we wanted everybody to have a basic understanding of adverse childhood experiences. And I want to just make a little side comment here. I'm a very interactive presenter and I don't love talking at people. So if you have something that I'm talking about here, so we reviewed kind of the first section about what are ACEs and you're feeling a little bit lost, you have questions, raise your hand. We'll have time for more formal Q&A at the end, but I don't want anybody to feel like you can't ask me a question, okay? Just because I have a clicker doesn't mean we can't be informal and answer some questions, okay? So the second part of what we did through the Children's Health Alliance is we did what we called CICT training, and that was short for Compassion-Informed Care Training, otherwise known as Trauma-Informed Care Training. What is compassion-informed care? Well, trauma-informed care is an approach to engaging with people with histories of trauma that recognize the presence of it in symptoms and acknowledges the role that that's played in their life. When we were thinking about this from a medical standpoint in a pediatric office, we decided we would think about it more of like compassion-informed care. Let's just assume, because we know about ACEs, we know that 64% of people have at least one ACE. 12 out of every 100 people pediatricians interact with are going to have 4 or more ACEs. Average pediatrician sees somewhere between 15 and 25 patients a day. They're going to see a lot of people who've experienced trauma in their lives, right? So we wanted to take the standpoint that we're going to assume that people have experienced trauma, either acute or complex, at some point in their life. And we wanted to train the entire office staff from the front people who are scheduling you and receiving you, all the way back to your physician and MA on what it means to be a compassion-informed environment. So the definition of compassion-informed care was caring for patients and families with full knowledge that trauma symptoms and effects and stresses treating all people with compassion and respect. We wanted to use a positive psychology approach while emphasizing strengths and assets of families rather than dysfunction or disorders. So I want you to think about a compassion-informed office. All of you as parents take your kids into pediatricians or family practice offices. Even if it's not a practice, that's associated with the Children's Health Alliance, think about this as your Bill of Rights, right? Every time you walk into your physician's office, you have the right to have a provider who knows what trauma is and what it looks like, to avoid triggering you and increasing your trauma, to restore safety for you, strength and self-worth of both you and your child, and to have all people in that medical office treated with compassion and respectful care. So think for just a minute about the pediatric office or the family practice office that you go to. Are you being treated in a compassionate manner? Is your child being treated in a compassionate manner? And what can I do to advocate for myself or my child? The story that we sometimes talk about as providers when we're doing the compassion-informed care training are the story of kind of a harried mom who comes into the front desk and she's 15 minutes late for her appointment, and she's got 2 kids trailing behind and they're fussy and she's fussy for sure and she's tired, and she gets there and non-compassion informed care person might say, oh, you're late for your appointment, we'll have to reschedule you with Dr. Smith. And the mom's overwhelmed and she gets really belligerent. She starts yelling at the front office staff and they don't know what's wrong with her. And now they're talking to the other office staff about what a horrible mom this is. And, why are the kids so whiny? Because, she obviously isn't a good parent, right? You get the idea. One of the first things we did when we talked with all of the pediatric offices through CHA was to say to them, instead of wondering what's wrong with you, ask instead, what's going on with you? What's your story? Just that little shift in how we question something can bring a whole different type of compassion to someone. I try to do the same thing even when I go to Starbucks or I'm in line with the grumpy checker at Safeway. I don't know what anybody's been through on a given day. I don't know what their ACE score is. I don't know the story that they bring with them that day. But being compassion informed means that I'm aware that there are trauma triggers in everybody's life, small and big, what I call small T trauma and big T trauma, that we should be aware of, and that all people should be treated with that knowledge and respect. So first step was understanding ACEs. Second step was understanding what compassion-informed care looked like. The third step was, okay, we know what ACEs are. We know they're bad, right? We don't want to experience too many of them, but we know that they're there. And so how do we begin to mitigate the effects of adverse childhood experiences? Again, Robert Bloch had said this is the single most unaddressed health problem facing our nation. So as we looked at studies, what we realized is that resilience, teaching resilience to families, to providers, to teachers, to people that interact in the systems in which children live, is the solution. The benefits of resilience we know from research is that it improves academic performance, it increases optimism for both parents and children, increases problem-solving techniques, supportive relationships, and can prevent and improve symptoms of anxiety and depression. There have been several studies that have been done, but for instance, the Pennsylvania school system created a resilience building program that showed a reduction of anxiety and depression amongst their students. In the back of your handout, you'll see a link to Paper Tigers, which is a movie that was done to showcase resilience interventions that occurred in Walla Walla, Washington. And in fact, what they saw is once the teachers were trauma-informed and resilience-informed, these kids a year later looked dramatically different. Depression and anxiety went down. Truancy or skipping school went down. Test scores went up. Kids felt better. There was less suicide, less depression and anxiety. So we're finding is that even though you may have very high ACE scores, the Walla Walla study was significant in that no matter how high the ACE score was, having a resilient building school had a dramatic effect on their outcome and increase the resilience amongst all students. So more specifically, what is resilience? Resilience is the ability to recognize, face, and manage or overcome challenges, and to be strengthened from that process rather than defeated by it. Here's the good news. We're all born with it. All of us, all of your children, when they were born with the ability to be resilient. And it can be taught, modeled, and improved upon. As a psychologist who works with parents every day, this is good news, right? That means that all of you who were counting your aces before and thinking that you are doomed and your children are doomed, there's good news. You're not doomed. Resilience is innate in you, and it's innate in your children. And often it's just a matter of having the right tools to intervene in a way that feels healthy for you and your children. Here's a metaphor that we often use about resilience. If you take a ball, like a basketball, that doesn't have any air in it, or even a medicine ball, and you throw the ball down on the ground, what does that ball do? Thunk, right? It absorbs the whole impact of that. It absorbs all of the weight. It becomes kind of misshapen. But if you take a basketball instead and you blow it up full of air, and then you bounce the basketball, what's it do? It bounces back, right? That's what we think about when we think about a metaphor for resilience. We don't want hardships and difficulties or trauma to have the full weight and impact. And in fact, they won't if we have strength building strategies for our children that help them bounce back. Resilience trumps ACEs. Using compassion-informed work both minimizes the potential for further trauma and provides emotional support for the entire family. Positive coping tools, which you're going to learn some of here tonight, in what we call anticipatory guidance, meaning anticipatory guidance, all of you have down pat as parents. It means your child does something and then you do something. And then later they do it enough that you can anticipate that this is going to happen, right? Those of you that picked up your kids from school today and you're like, oh, you're going to need a snack because you get kind of grumpy. That's anticipatory guidance. Those of you with teenagers who, they get into the car and they're a little bit sullen and you think, oh, you know what? You just need to connect with me for a little bit when we get home. Or we need to have some time where you're unplugged from everything. You're anticipating the need of another person. So we know that creating positive coping tools and giving anticipatory guidance provide a framework for trauma-informed work that reduces the effect of adverse childhood experiences on children. Okay. So, what are features of resilience specifically? You have kind of a framework of what resilience is. We're all hopeful now because we had really bad information at the onset that we were all doomed. But in fact, now we know we can build resilience. There are lots of models of resilience. Ginsberg's model of resilience, Kinnenberg and Blostein's, Hawkins, Castle, Benson, 6 strengths, developmental assets a lot of people are familiar with. At the Children's Health Alliance, we chose to focus on a couple of key features of resilience. One, we use Ginsberg's 7 C's, partly because he's also a pediatrician practicing and endorsed by the American Academy of Pediatrics, and also because the 7 C's are pretty darn easy to remember once you get a hold of them. So let's just review what the 7 C's are. The first one is competence. Excuse me, I lost my little mouse here, so I'm trying to re-find it on the computer. There we are. The first one is competence. When we notice what young people are doing right and we give them more opportunities to develop those skills, then we're going to encourage competence and make them feel more able to perform the task that they're doing. When we undermine their competence, when we don't allow them to perform tasks or learn new tasks, and we don't allow them to recover after they fail. Confidence. Young people need confidence to be able to navigate the world, to think outside the box, to problem solve and recover from challenges. I know you've probably all seen that little video of the boy, he's throwing the ball up in the air. This to me is like resilience, confidence in motion, right? He throws the ball up in the air and he swings and he misses, and he throws the ball up in the air and he swings and he misses, and he throws the ball up in the air, swings and he misses. He goes, man, I'm a great pitcher. That's confidence, right? That kid has confidence. He was able to bounce back from that. Connections with other people, schools, and communities, right? Kids who are connected with their school, with their church systems, with other families, the village that we talk about that is important to raising children, have greater sense of resilience. Character. Young people need a clear sense of what's right and wrong. And they need to know that they are committed and your family is committed to the integrity and a moral sense of developing that character for them and with them. Contribution. Young people who contribute to the well-being of others receive gratitude rather than condemnation. And they learn naturally that contributing feels good. Parents all the time ask me about chores when they come into my office. When is the right time to start chores for kids? And I say, you're asking me about your 12-year-old. We got some problems, right? Kids naturally want to contribute to the world. 2-year-olds, 1-year-olds can help pull laundry out of dryers and stack dishes and vacuum and contribute to family chores throughout the household. So if anybody's telling you your kid's not ready to do chores yet, that contribution piece is really important for them. There's a couple kids in the room that are like, ooh. Coping. Young children who possess an ability to cope and work through adversities have a higher sense of resilience because they know that they have the tools on board that they need to move through a difficult situation. And finally, control. Young people who understand privileges and respect and earn it through demonstrating responsibility are going to learn to make wise choices. It's really important for kids to have a sense of what we call locus of control. Are the things that I do meaningful, and do they have an impact on the environment around me, right? We see 2-year-olds and 3-year-olds, those of you with toddlers, right? Very strong sense of control. We see that again when kids become teenagers. What do they want? Lots of control, right? They want to have their own independence and autonomy. So we see these 7 C's revisited over and over and over again throughout your child's development. Questions on the 7 C's? Okay. My clicker doesn't want to work. Yes?
How do you help a child who is going through these adverse experiences when one parent or the other is actually causing them to a loss of control or taking away their ability to cope? How do you deal with that kind of situation?
So the question was, how do you help a child have a sense of control and coping when it may be the other parent who's actually causing that loss of control? We're going to come back to that probably in a little bit when we talk about connections and meaningful connections. It's actually a really important question because one of the primary underpinnings of all of the things that the resilience curriculum is built on is that parents are the primary attachment model for their kids, and therefore all of their resilience and coping comes from that child. So it can be really confusing, first of all, for a child whose parent is giving them a different message. And so if I don't circle back to it later, be sure that I talk to you later when we're talking about interventions that I refer to as creating a narrative for that child so that they can decipher who are good, healthy people to get information and advice from and who are people that aren't. We'll talk about that in a moment in what the intervention also called the circle of support. Okay. Here are some other important features of resilience. Social competence for children. It's really important, right? Their responsiveness, their cultural flexibility, their empathy, and communication skills all give them a sense of feeling competent socially. Features of resilience and autonomy. It's important for kids to feel like they are autonomous individuals, that they have a sense of identity, self-efficacy, self-awareness, and task mastery. Problem solving, really important. Problem solving, to be able to plan, help seek, and critical thinking are really important. In fact, if you talk to my friend Laura, who's the previous admissions director for St. Mary's down in Northern California, she talks about kids coming to college now without the ability to problem solve on their own, and parents who are still calling universities on behalf of their children to problem solve for them. If you want a child to be able to have resilience, to be able to bounce back, they need to feel competent and they need to feel like they can problem solve on their own so they can move out into this world. And they need to have a sense of purpose and a belief in a bright future. They need to have goals and direction, educational aspirations, optimism, faith, and spiritual connectedness. From the time my kids are really little, I ask them, what do you want to be when you grow up? Not because I thought that my daughter really would be a ladybug, although she was really committed to it for a while, but because I wanted her to know that there was a future beyond what we were doing in our family. And we have lots of discussions about future. We have lots of discussion about our what I call our we culture in our family. In our family, we value education. In our family, it's really important that we support your dreams. What do you want to do when you grow up? What dreams do you have as you get older? So I'm asking lots of questions about their sense of purpose and having a bright future. Again, these factors that promote resilience can be taught. Remember, it's not just an acute trauma that can cause long-term health effects, but it's cumulative risk that's more predictive of developmental outcomes than any one single risk factor. Therefore, we know a reduction in that risk can produce positive outcomes. So we want to create promotive factors, or factors that are the opposite of risk factors. They operate to actively promote positive development. So I think I'm going to be able to play the video. Last time it didn't work very well. Let me see if it has a little... I don't think you can hear that. There's a bunch of kids yelling for my son as he climbs a 50-foot wall. Can you hear that better with the microphone down there? No? Okay. I didn't want my son to necessarily build resilience that day. It was really high up, and I didn't necessarily trust the rappelling folks that were down on the bottom of the ground. He's 3 in that picture, and he was at a birthday party with his sister's friends, so they were all 5 and 6. But you can hear them and I'm sorry you can't hear them in the background. What you would hear them saying is, "Go, Jack! Go, Jack!" And he gets to the top and they just explode with encouragement. Sometimes even as parents, when we don't want to build our children's resilience and give them that competence and confidence and character development, all of those 7 C's that are really important, they need to do it. And they'll tell you when they're ready to do those things and take those launches out to explore their world. We know what children that are resilient look like. Decades of research show that children who are resilient possess these qualities. They feel special and appreciated. They set goals and expectations. They problem solve. They view mistakes as hardship. They view mistakes and hardships as challenges versus stressors. They have good interpersonal skills. They seek assistance and comfort, and their locus of control is strong. Right? That's the list we want for our kids, right? We want them to have all of those features of resilience. And the good news is that we can teach them a lot of that. So again, here's your framework for resilience. And I want you to just take a few minutes and think about your family. What qualities of resilience does your family have? So look on this list, because we're going to come back to it and we're going to look at specific interventions. But just think for a minute. What qualities of resilience do you feel pretty sure that you and your kids already have, or that you and your partner or spouse or family members encourage and promote? Some of us are really good at encouraging coping tools or character development. Maybe we're not as good at encouraging connections. Maybe we're not as good at helping our kids problem solve or encouraging them to do so on their own. So just think for a second, take a little personal inventory of what you might feel good at and what you feel like you need a little bit of work in. Okay, so when I went to develop the curriculum for resilience for pediatricians, I was asked to develop interventions that were specific to kids across ages and across development so that they could teach them at their well child visits. So there may be some of you whose pediatrician or provider is a member of the Children's Health Alliance, and you'll see one of these interventions, you'll be like, "Ah, Dr. Meyer just taught me that last week when I was in her office." And if that's the case, awesome. A lot of pediatricians are being trained on these resilience interventions. But as I developed the curriculum, I had to stop and go, okay, wait a second, there's something missing. And I went back and looked at, okay, what do I need to believe as a psychologist that is there and present and true before any of these interventions will work. So these are the core assumptions that I think have to be in place. There are 3 for providers and 3 for parents. So from your providers, your medical doctors, right? I want them to come at you with a non-judgmental stance, right? When I had a baby, I wanted to be able to be that crazy mom, right? I wanted to be able to call my pediatrician and say, I don't know what's happening. I don't know why they're doing that. And I wanted to be able to be embraced by my pediatrician or provider and know that every question was an okay question to ask. We want to remind parents that there are shared goals. Dr. Matthew, who's not here tonight, but she's really fabulous at asking parents when their kids are very little, what are your goals for your child? And she writes them down actually in the electronic medical record. You know, I want my child to be healthy. I want my child to be strong-willed. I want my child to be happy and successful, or whatever the case may be. And she writes it down. And then later, when your child's 3 or 5 or 12 and you're complaining about how strong-willed they are, she goes back and she says, remember, you wanted that strong-willed child? But essentially what we want the provider to say is, I have those shared goals with you. I'm not just here for the medical health of your child, but the social emotional health of your child as well. And we want to create we language, that we're working on this problem together, or we're going to tackle this until we figure out what's going on. So in order for any of the resilience interventions to work, right, the tack that I took with it when I was talking with pediatricians is I needed them to first, before they taught any of this, have a non-judgmental stance for their patients, have shared goals, and create we language. And I have 3 for you also. If this is going to work, I need you to know that children require unconditional love. Stop. What does that mean? What does unconditional love mean? Somebody throw it out.
No matter what.
No matter what. No matter what. I mean, like, even if they fail a test? Even if they date that boy? Even if they're the bully? The perp? That you're there for them no matter what. You love them no matter what. You may not like some of their behaviors. You may have long discussions about it and consequences for them. But yes, you will still love them, even when they mess up. And we're going to talk about that in just 1 second. A specific intervention you can do right away if you're not doing it already. I also want you to know this, that your kids regulate their behavior based on expectations from you. It's not a do as I say, not as I do. It is monkey see, monkey do. Okay? They are managing themselves because of who you are, not because of who you're not or what you'd like them to do in spite of what you're doing. They are watching what you do every day. So if you act kindly, they will act kindly. If you act grumpy in traffic, they will be grumpy in traffic. That was an overshare. And I also want you to know that you're the primary role model for your children, right? That these tools of regulation and resilience come from the premise that primary attachment systems, you, the parent, and that might be in your family also a grandparent or a step-parent or an aunt or an uncle or a godparent, may not just be biological parents, maybe a village of people, but those behaviors are regulated through the parents or the primary attachment systems. So we get into some of the meat of it, but right away, I'm going to talk to you about one of these, the 6 core assumptions and what's called an I love you ritual. Try to build a daily ritual into your routine that connects with your child. We know that rituals and routines build confidence in their kids. I want your kids to be so bored knowing how unconditionally you love them that they actually roll their eyes at you when you play this game. So I love this, right? I say to my kids from an early age, we're going to play a game. You're going to tell me something you could do that I would stop loving you. And I'm going to tell you when that happens. And they're like, oh, yes. Right? And it's amazing whether your kid is 4 or 5 or 16 or 17, the things that they will put out on the table. And they're really going to test you to see if you're really going to hold true. And I'm not saying you can't give disclaimers, but every time your answer has to be, and you must genuinely feel, because they will know if you don't. I will still love you. I will still be there for you. I will be there to pick up the pieces, right? So 5-year-olds might ask questions, you know, like, what if I'm mean on the playground? Or, you know, what if I don't have any friends? Or what if I get sick? Or, you know, and then before the abstract reasoning and formal operations occur, they'll be like, what if I kill someone? You know, your kindergartner, what if I kill someone? Or, you know, what if I come home and I beat up daddy? And I still love you. I'm going to talk to you about, you know, hitting daddy. But you're going to tell them over and over and over again why that relationship with you is always intact. I had a girl that I was working with who really was questioning that with her parents. And we were doing a version of this I love you ritual, and she was 16 years old. And she said, what if I had an abortion? And the room got quiet. And the mom was like, is there something you want to tell me? And she's like, what if? She wanted the answer. She wanted to know from her mom first. Alfie Kohn calls it a relationship rupture or a love withdrawal. When we put conditions on the relationship we have with our kids. Think about the last time you were, and we all do it, right? We all do kind of these unhealthy behaviors where we're really mad at our kids and they had toys all over the place, or they didn't study for their exam, and like, you know what? I'm not going to read a book to you tonight because I'm just not going to do that. It's a love withdrawal that we take from our kids. When it's a ritual that's built in that your child's depending on for their regulation every night, and we take that away suddenly, that's what we call a love withdrawal. I know all of you are feeling really bad right now. I do the same thing. I mess it up all the time. But then I go back and I say, you know what? I'm sorry. Books are something we do every night. I didn't like that you didn't pick up your toys when I asked you to. We're going to make sure that we do that together. Or tomorrow we're not going to get those toys out. That's a more natural consequence for leaving them all over the place. Or, you know what? You fudged on your homework. So I'm not going to not sit with you and say goodnight to you tonight, because that's about us, right? A love withdrawal is something that you take away that's about you, versus saying to your kid, you know what? So tomorrow night there's not going to be any screens because you kind of dinked around when you're supposed to be doing your homework. Does that make sense?
So, I try to go as a parent with the strong, authentic, strong emotion.
Mm-hmm.
Like when my child does something, like a 3-year-old. So like when he got in a fancy face cream and put it all over his shirt, I was frustrated,
Mm-hmm.
you know, and I try to use those words about my emotions and stuff. And sometimes I'm like, I don't want to talk to you right now because I'm frustrated
Right.
by whatever. So I'm just trying to like clear the line between a love withdrawal and like, I don't want to talk to you right now because I'm pissed off.
I need a break. Right.
Right.
Absolutely. Needing a temporary break from a child, right, because you're dysregulated and you need to calm down, is different than saying to that child, you know what, we're not going to be together in a fundamental way because I'm mad at you. So for instance, if you said to him, I'm not talking to you anymore today. That's very different than saying, you know what, I need a break because this really made me grumpy and I feel frustrated about this. So give me 5 minutes, I will be back with you. I need a mommy break. That's different than saying, you know, screaming at the child, calling them names, telling them they're stupid, you can't believe they did that. This happens in families, that's why I'm saying that. I'm not going to talk to you for the rest of the day, right? Things like that that are emotionally punitive about a withdrawal of you in the relationship. It's a really good question. Thank you for the distinction. Yeah.
What if it's about an abusive teenage boy and it's like, nah, you're not living in my house, you're going to your dad's. So further notice. Is that a love withdrawal? It's about safety?
So so the question is this: if there's an abusive teenage boy in the house and you're saying you got to go to your dad's for a while, right? We're talking about delivery here, right? So you know how you deliver that message to your child. If you say to your child, you know what, I don't want you in my life anymore. Good luck at your dad's. That's a love withdrawal. If you say to your teenager, you know what, this family isn't safe. And in our family, we don't hit. And so I need you to be in a safe place because I want you to be part of this family when you can be safe. See how that feels different? Love withdrawals can be about semantics, right? But your kids remember how you delivered those messages. You remember, all of you remember messages from your own childhood of love withdrawals and conditional messages that your parents gave you. Good questions. This is the resilient house. So I just wanted another way for you to see this, right? The foundation upon which all the resilience interventions are that we're going to talk about after the break is based on those 6 core assumptions, right? That parents provide their children with unconditional love, that they have expectations that come from you, and that you know you are the primary role models, and that your providers are coming at a non-judgmental stance with shared goals and creating we language.